All right, well, welcome to our special session on geospatial data, dashboards, analytics, and scientific communication, lessons learned from the COVID-19 pandemic. This session was organized by Paola Zamperlin from the University of Pisa. And my name is Aileen Buckley. I'm a cartographer at Esri on the Living Atlas of the World team, and I'll be moderating the session today. I'm joined by a number of colleagues who will serve on the panel. Dr. Esti Garrity, MD, is our Chief Medical Officer at Esri. And Shen Dong, who goes by Frank, is a PhD candidate at Johns Hopkins University. Jim Harries is a geographer at Esri, also on the Living Atlas of the World team. And Johnny Campanile is a project manager at Esri Italia. Each of the panelists will offer a short presentation of about 15 minutes. And then ICA President Tim Trainor and I will direct a discussion. We hope you'll be able to contribute questions for our panelists or observations for discussion. If you do, then just sort of speak up a little loudly so we can hear you. So before we get started, let me just say a few words to set the stage for our session. The concept of place has always been important to health. For example, around 400 BC, Hippocrates wrote a treatise called On Airs, Waters, and Places that examined in depth the different sources, qualities, and health effects of water, cities, and climate. Fast forward to today, and we see that the location intelligence technology known as GIS has become critical in health and healthcare. Over the past 2 years, the global pandemic shone a light on the connections between health and place. Even the very definition of pandemic, like epidemic, is place-oriented. An epidemic is a disease that affects a large number of people within a community, population, or region. And a pandemic is an epidemic that's spread to multiple countries or continents across the world. People who had already embraced GIS and integrated it into their everyday workflows were inspired and sometimes forced to rethink the connections between place and health. Even though Esri has been helping to forge these connections for almost 30 years, GIS inspired people to apply spatial thinking and the associated skill sets to the global pandemic crisis. The Johns Hopkins COVID-19 dashboard made obvious the connections between not just place and health, but also time. In fact, the connections were so well shown that the dashboard has received trillions of hits from people wanting or needing to know what's happening at scales from the world to their own locality. The collection of the data and the development of the data services behind the dashboard made it feasible for others to localize that information for the populations that they serve. We saw hundreds, maybe thousands of derivative dashboards and other apps that showed that there were multiple useful ways of looking at the pandemic. The pandemic happened at a time when there was an opportunity through GIS to make better decisions based on a global perspective and a geographic perspective. So together they helped to provide a cogent global understanding. There was an opportunity to go beyond the map to all the other activities that GIS supports to address the pandemic. And these are the things that we're going to talk about today. Esti Garrity will share with us the breadth of GIS applications in health that happened over the past 2 years. The Johns Hopkins map and dashboard illuminated the opportunities for data sharing, something that Frank Dong will be able to speak to. There were also opportunities to use that collected data to support the development of other apps, and Jim Harries will describe some of these. Many people or agencies also saw a way to leverage the original dashboard and other apps for their own areas of interest. Johnny Campanile will show us some of these examples. So at this point, I'll ask Esti to kick things off with her short presentation.
Thanks, Aileen. And I will just take a moment to share my screen as that opportunity comes up for me. Okay, I see it. Thank you. And then I'll ask one of my colleagues to verify that you're seeing my screen.
It's good. Thank you, Esti.
Perfect. Okay. Well, hi, everybody. I wish I
All right, so we have a connection issue for those that can hear. It's just gone quiet. And it's Este's connection, I think, because we're seeing you move, both Frank and Aileen. So I can see you move, but I can't see Este. She's gone off. I don't know what you want to do, Aileen, whether you want to go to Frank or...
I am going to go to Frank. Frank, Esty will have just spoken about some of the ways that GIS has been used for looking at the global pandemic in different ways, and not just the global pandemic, but other interests and areas of health concerns. So that's sort of a lead in to what we're hoping that you'll be able to share with us today. So why don't you take it from here, and you can share your screen as well.
Okay, I will start to share my screen. Thank you.
All right, Frank, you're up and running.
Yes. Is everything good? The
Yes,
slide?
yes, everything's good.
Perfect. Hello, everyone. This is Frank, a third-year PhD student at Johns Hopkins University, working with Professor Lauren Garner in the Department of Civil and Systems Engineering. In this presentation, I'd like to share some background about our Johns Hopkins Coronavirus Dashboard. Specifically, I will discuss the data collection and sharing strategy, some of the most pressing challenges we have been facing, and solutions we have developed along the way. So you may have been very familiar with this dashboard, which we released in January 2020, almost 2 years ago. We collected and displayed cases, death, and vaccination data for every country in the world. The most recognized part is the map shows big red dots representing total cases in the past 28 days. The data is collected at 3 different spatial resolutions. For instance, we collect the US data at the county level. Countries like Canada and the UK are at the subnational level, and the rest of the world, such as most countries in Africa, are at the country level. In total, we are collecting data for over 3,500 locations on an hourly basis on a rolling 24/7 timeline, which amounts to over 10,000 data points per hour. And the left-hand side, they are ranking the countries by the cases in the past 28 days. And the epic curves on the right-hand side are weekly cases, weekly death, and the weekly vaccine uptake. You can switch to daily plots by clicking on the tab. Down below, we also provide map layers illustrating different epi metrics. They are the total cases map, the incidence rate map, the case fatality ratio map, as well as the doses administered data normalized by the population. These views are very important to understand the relative impact of COVID around the world. We also customize the dashboard for mobile devices. The mobile version provides the same information as the desktop version. Oh, sorry, there's a... Okay. The mobile provides the same information as the desktop version with a more compact view, and you can also scan this QR code to check it. Oops. Sorry, someone is annotating. Let me turn this one off. Sorry about that. All right. All right. We also collaborate with Johns Hopkins Coronavirus Research Center and the Civic Impact, and we created a US-specific coronavirus dashboard. If you click on a US county and then click the infographics in the pop-up window, you will get a county-level demographic details and the public health facility information. We're also proud to become one of the best inventions of 2020, chosen by Time magazine. And we started this effort when there were only a few hundred reported cases of COVID in China, where my family and friends live. We began collecting and sharing the data because we recognized the value of a timely and accessible data set on emerging infectious disease. These efforts will improve our understanding of novel virus, predict what will happen in the future, and guide evidence-based public health policy. The first version of the dashboard was launched on January 22nd, 2020, and this is also a critical time point, since one day ahead, the US reported its first COVID case, and hourly later, the initial epicenter, Wuhan City, was locked down. And this is the first tweet promoting the dashboard sent by Professor Garner, my advisor. So within a couple of weeks, the dashboard had drawn attention from all over the world. On March 29, 2020, we recorded the highest number of requests in a single day, which is 4.6 billion requests. A request here means a click on the map or data pull request sent to the server. In total, the dashboard has gained more than 222 billion requests. Users around the world have contributed more than 3.5 billion views. Next is about the data. So in the academia, there is a saying, garbage in and garbage out. Therefore, we work very hard to provide the best quality data that is available in real time. However, as almost as here know, this has proven to be a quite daunting task for COVID. To begin with, I will introduce how we collect and share data. Our data pipeline is always evolving. In the early stage of the pandemic, not all governments were prepared to report the COVID cases in a standardized way. In the first month of the dashboard, we had to manually seek out reliable data from a variety of sources, including health departments, news media, and even Twitter and Facebook feeds from governments. After translating and putting all data under a unified table, we shared the raw data through GitHub and Esri feature service. By early February 2020, it became unsustainable to maintain the system by human machines. What are human machines? I'm one of the human machines, since the outbreak was becoming increasingly reported in new locations. So we quickly focused our efforts on automating the process of data collection. During the same period, we also started a design and a test which is called Data Anomaly Detection System. This system uses different logic rules to identify a potentially anonymous point. For instance, thresholds on proportional case and death increases, or total number of new cases and death at a single point of time. These anomalies will be flagged and held aside for human review before being published. I also want to highlight that this system is intended to ensure the data we are collecting from the source exactly match what is shown on our dashboard and published in our dataset. It is not designed to correct or smooth the data that is published by the sources, as we feel our role is to provide an aggregated dataset that is one-to-one matches what is publicly provided by the public health authorities in each location. And it is up to the individual users of the data to interpret this data and adapt it as they need. From the very beginning, we understand how a convenient data sharing platform could make our life easier, specifically for epidemiologists and the government officials. We therefore post the raw data on GitHub on a daily basis, and this is the link to our GitHub repo. You may also wonder who can use this dataset, and my answer is very simple: everyone. The data is available under the Creative Commons Attribution 4.0 International License. It allows any user to distribute, remix, tweak, and build upon our data, even commercially. Here are some of our users: the US federal government, the German government, and the Italian government, news media, such as the CNN, Wall Street Journal, and Google Maps. We also encourage any research groups to use our data, and some examples are our wording data from the University of Oxford and COVID-19 Focused Hub and the US CDC. We always facing many challenges about the data visualization and data validation, and I will introduce some examples that give us lots of headaches. In the backend, we regularly compare our data against other independent sources such as WHO, US CDC, and New York Times. If you compare our French data with WHO's, you may find we are consistently higher than them. especially in the early stage of the pandemic. There are two reasons for this. First, we define France to include its European part as well as 10 other French overseas territories, such as the French Guiana and Martinique. Second, our definition of case is more inclusive than that developed by the French Ministry of Health or WHO. We included a subset of several tens of thousands symptomatic nursing home residents who were not tested. For most of 2020, this resulted in our case count being higher than that reported by WHO or the French Ministry of Health. And here is our current data source for France. Another example of a challenge we have to deal with is from Turkey. For a variety of reasons, locations often report large increases in cases or deaths in a single day. This is usually due to some kinds of challenge in reporting rows or case definition, but can also be back-distributed data. It is hard not to notice this huge spike in the daily case plot for Turkey of nearly 1.5 million cases, which when added completely distorted the global time series plots. Our anomaly detection procedure caught this spike, but when we reviewed it, we found that the Turkish Ministry of Health started including asymptomatic cases on December 10, 2020, and this number was consistent with the country's reporting. Therefore, this spike was still published in our system. When this happens, we reach out directly to the source and try to get the necessary data to back-distribute these dumps. However, for the case of Turkey, we did not provide a back distribution for those cases publicly because they didn't provide. So we couldn't do anything either. By the way, if you know anything about how to fix this spike, just message us. Thank you. And beyond just the data issues, another challenge we face in regarding data visualization and privacy protection. If you still remember the Diamond Princess cruise and its outbreak, you may also remember the US government tried to evacuate nearly 400 citizens back to the US. And those evacuees were scattered across the US in hospitals and military bases. This gave us the question of how to represent those patients on the map and also in our data product. On one hand, we knew some, but not all of the exact locations. On the other hand, we did not want to track each individual. As a temporary solution, we aggregated all those patients as one unit, represented by one red dot, you can see over here, and placed it on the geographic centroid of the US continent, which is somewhere in Kansas, this one. But the next day, we received lots of complaints from local residents and the city authorities in Coffeyville, Kansas. That's where the dot is. They concern about the new COVID hotspot in their apartment complex. To address this issue, we reassigned that dot to a null island with latitude and longitude equal to 0. This location lies to the west coast of Africa. We eventually made it invisible on the dashboard, but still included in the open data product, so that our case totals are inclusive of those patients. It is this kind of challenge that has required our team to spend almost as much time communicating with media and the journalists as actually building out this data infrastructure. We also received many questions asking how often we update the data. Well, the brief answer is we ran the global scraper every half an hour, update the statistics on the dashboard every hour, and update the GitHub repo once a day. And the day stops at midnight on the US Eastern Coast. Precisely, it's from 3:30 to 4 a.m. UTC time. We admit there is no perfect solution, as this is a pandemic and the data is updating all the time from countries around the world. And here's an example, a very extreme example of this challenge. And this one is from Israel. They update the multiple time per day without a regular schedule. So depending on when you draw the chalk line, the daily data may differ between our product and their sources. So we do our best to align our data to match what is reported by each country. Well, there are many other stories about data reliability and maintenance, and I can go on and on for days. We are always thinking about how data reporting can be improved moving forward, and we believe the answer lies in data standardization and the data democracy. Data democracy, in our eyes, means making the public health data more reachable to the public. First and foremost, we call for a standardized reporting system, which includes a clear definition of cases and death. Second, we call for a consistent reporting medium, such as the scriptable web page, the feature service, or a nicely built online table. This means not having a manually copied data from figures in images and PDFs via randomly posted Twitter or Facebook feeds. Third, the health departments and local authorities need to provide data at a higher granular level, such as county or census tract. That information is more useful for scientific research and policymaking than the general state or the country level report. And this can be done while also protecting patients' privacy, especially for less populous locations with only a few cases. Such an established system will both help us make sound and timely decisions when faced with the next potential outbreak, and it can help us establish the public trust to combat health-related disinformation. In the end, I would like to say thank you to our excellent teams from Johns Hopkins CSSE, Applied Physics Lab, JHU Library, and Esri. I also like to acknowledge our sponsors. It is their sponsorship that makes our Johns Hopkins University not only famous for its medical school, but also famous for the coronavirus map. Thank you. Maybe back to Esti.
Thanks, Frank. I am back, and I'm going to follow your lead this time by not turning on my camera to see if that improves my bandwidth. Sorry to everybody for that mishap. Doesn't happen too often, but when it does, it's always concerning. So somebody needs to pass me the ball on the WebEx so I can share my screen.
Esti, yeah. It'll be just a second.
Sure. All right, I see it. Thank you.
Good. And you're up and running.
Perfect. Thanks for that acknowledgement. So as I was about to tell you before the internet so rudely bumped me off, and you all know it, GIS in health has gotten so much attention over the last 2 years. It has been used by governments, academics, nonprofits, healthcare organizations of all kinds, just really across the board. And they've been using it for all sorts of purposes. So in this short presentation, my goal here is to share a few of the most common applications of GIS for pandemic response. And I hope that you'll also recognize that these workflows are really relevant to all of our future preparedness needs and for other health challenges across the board. So keep those in mind. The way I'm going to approach this is by covering 5 key areas of applied GIS, starting with map-based situational awareness. You've already heard something about that. Then I'm going to highlight some key analytics and site selection methods that improve planning with an emphasis on equity. And then I'll show how GIS has been applied to connect people to the resources that they really need and communicate up-to-date information with the public. So I have to say, there's no doubt that people have been getting their pandemic-related situational awareness from mapped data. And you've already heard a great deal about the famous JHU dashboard from Frank, but I wanted to make a few additional points about the importance of this dashboard to GIS in health. So first, it really awakened the world to health GIS in a rather dramatic way, as we all know. And you also heard that the Johns Hopkins team prioritized data sharing, which was a huge enabler for thousands of organizations so that they could visualize and analyze and plan and make better decisions for their localized COVID-19 response. This was hugely important. And furthermore, I would say that the Hopkins data really exposed gaps, lots of gaps actually, in our various national and local public health systems related to data collecting and data sharing and interoperability. And I loved that list that Frank shared right at the end. But I think that also the magnification of these gaps has been so profound that I really believe we're going to see real solutions on the near horizon. And finally, the dashboard, because of its regular updating, built expectations among all of us for that real-time and near real-time data. And that too will probably forever change us. We really never had that in health before. Now, again, because of the open data sharing, others could consume this data to create what turned out to be thousands of similar dashboards that provided that localized situational awareness. And at Esri, we were also enabled by the JHU data, and I'm just giving you a high-level overview and a preview to what Jim is going to go into more detail on. But this particular map shows weekly case rate trends where gold indicates improving case rates and purple signifies worsening rates. So I always say gold is good and purple is poor. But an improvement trend on that map doesn't necessarily mean that things are good. And that's where this Esri map comes in. Here we can say where each county is in terms of the pandemic phases. Clearly, most of the country in the US is in epidemic trend, the worst trend, even though some are doing better within that trend. And then using an even higher level view, we have this Esri map called COVID Pulse that uses a visualization technique called spark lines that display really what I would say this is a full history of the pandemic through normalized trends for each state. And if you zoom in, you can see them for each county. So you really need all of that information to have good situational awareness. And situational awareness does go beyond the Johns Hopkins data. As much as we love it, people are doing other things. Like here, the Africa CDC is sharing their situational awareness around vaccine delivery, vaccine brands, and the variants of concern. And the state of Missouri is just one example among many jurisdictions that are testing their wastewater for viral shedding. And when detected, of course, this becomes an early surveillance indicator. We're also seeing this pattern used for opioids in the wastewater. Now, map-based situational awareness basically gives us the lay of the land. Then spatial analysis will provide stronger evidence for our planning and our decisions that we need to make. And of course, if you want to do great analysis, you've got to have great data. So one recent innovation that we've seen during the pandemic is this availability of anonymized and aggregated cell phone data. And that comes from organizations like Unicast and SafeGraph. Their data revealed social distancing behaviors and also visitation rates for businesses like grocery stores, like gas stations and home improvement stores. And this really gave us amazing insight into human behavior during the pandemic that was really useful for guidance and policymaking. And then we took that same behavior data and it could support enhancements like the one that we made to epidemiologic models like the CHIME model that are meant to simulate viral spread. So that geographic lens that we add to this accounts for the spatial variability in social distancing behaviors in disease spread, and therefore allows us to make more accurate predictions for which regions or which hospitals are going to be more impacted by COVID cases. We can estimate when that might happen and how long that surge might last. And going back to that same anonymized cell phone data, it's being used to estimate what turns out to be rapidly and dramatically changing demographics in many hospital service areas. And this is helping leaders to more effectively plan or adjust their near and long-term strategies. And this is one of my favorite analytical applications that looks at social distancing and weather. So here you're seeing that social distancing data from Unicast in this case, where red is an F grade, bad social distancing, and A is an A grade. So if we're looking at this in California, we can look at the date that the California stay-at-home order went into effect. Obviously, no social distancing before that, it wasn't required. But afterwards, we can see a really interesting difference that our coastal counties did quite well with social distancing, like San Francisco, really good. And the inland counties did a little less well with social distancing, although certainly improved from baseline. But then something happened in April. People started crowding at the beaches. So why is it? Why this change in behavior when there wasn't really any change in the pandemic needs for isolation? Well, we can look at other variables like temperature data. So we pulled in data from NOAA and we built that up as a time series in a way. This is called a voxel layer. So volume plus pixel is a voxel. And what you can see is in the darker orange kind of brown areas, those are warmer temperatures, whereas of course the greens and blues represent colder temperatures. So now we can do a face-to-face comparison validation of whether or not there appears to be a correlation between social distancing and weather. And we're now looking at San Bernardino. Esri headquarters is in that county. And sure enough, there is a strong correlation between warmer weather and less social distancing. So really important information to, again, help guide policy and decisions. Now, another interesting example is using GIS for contact tracing. So in ArcGIS Pro, many of you may be familiar, you can do link analysis, which really helps to better understand the person-to-person connections that, of course, are that traditional focus of contact tracing. And I have to say then, in addition, we can move this forward. We can apply tools from graph theory, like centrality, to determine the strength of person-to-place connections. And this turns out to be particularly important in this situation that we find ourselves in, where we have more widespread community transmission of disease. Now, throughout the pandemic, we have needed to stand up all sorts of new resources in communities across the globe. And as it turns out, this workflow of site selection is a common and very high value use of GIS. So we built a tool that performs that workflow of site selection in a really simple and automated way. So I wanted to show you this example that's focused on increasing vaccine coverage. So the process begins by just collecting and mapping the community's existing vaccination locations. So of course, those could be hospitals or community clinics or pharmacies, whatever you happen to have in that community. And then the user has to specify the geographic area of interest for the analysis. It could be anything from a country to a region, a city, a village, or even a custom area. Next, the user has to make a determination, a decision about what is an acceptable level of geographic access to community vaccination sites. In Los Angeles, it might be a 30-minute driving time, but in a more rural place, maybe it's 15 minutes of walking time or something else that would make sense for that geography. Once that information is input, the first calculation that the system does is estimate the percentage of the population that can actually reach one of those current vaccination sites. So now we need to work on the gaps, those places where people don't have good access to the vaccine. And so for this, we begin by adding in candidate vaccination sites. Those are shown on this graphic in gray. Now those could be anything that you might want to stand up. It could be parking lots if you're going to have pop-up or drive-through clinics. It could be blood banks or schools or convention centers. Any place where vaccine administration could reasonably take place. And then to add elements of equity that go beyond that geographic accessibility that we already have accounted for, we can include any and all factors that are relevant for this specific population. And then all of those attributes are used together as a weighting factor. So let's take a closer look at some vulnerabilities specific to COVID-19. So for example, some people have increased susceptibility to severe disease. They may have factors that put them in a position where they're more exposed to disease through their jobs or their living situations. We can also include various socioeconomic risks like race, vehicle ownership, language, clean water for hygiene, or a host of other relevant indicators of vulnerability. So again, all of those are included and become a weighting factor, and then we simply run the tool. In the end, the tool selects the fewest number of candidate locations that would be needed to close the geographic gaps while favoring the places with the highest vulnerability. Now, once you have all of your new resources or some of your new resources, you want to be able to get people connected to them. So how do we do that? Well, of course, Locator apps have sprung up for all sorts of things. And this one's one of my favorites. It comes from New York City, and their vaccine locator app not only shows the public where they can find their nearest vaccination site, what type of vaccine is delivered, but users can also filter by the locations that have open appointments on the days that somebody really wants them, when they have available time. Now, sometimes we've talked a lot about getting resources available to the public, but sometimes you have to actually take the resources to the people, like providing vaccines to homebound or hard to reach populations. So in this graphic, we're showing just a part of the process, but what we're showing is how GIS can optimize the routing for the mobile vaccinators, and that can help them better manage their time and resources. But we can also match up to patient preferences, like language capabilities, for example, and provide patients, customers with the reliable visit time estimates that is more convenient for their day. Now, finally, in this age of conflicting messages and misinformation, trusted health organizations really need communication tools that are clear and engaging and reliable. And a lot of people are turning to ArcGIS Hub to keep the public informed. It can hold embedded maps and apps that can help support clear information delivery around a specified topic. So in this case, we developed the Coronavirus Vaccine Outreach Hub solution to give that clear information delivery about the vaccination process. So one of the early apps that was included in this site was one that really provided what I would call digital triage, where residents could check their eligibility time-wise to receive the vaccine. Now, if they were eligible, of course, they were seamlessly connected with a locator to find a provider near them. And then they also have the opportunity to share their story with the I Got Vaccinated story map. And this is available to everyone, so you might want to take a picture or a snapshot of that URL on the slide. This story map is really intended to reduce vaccine hesitancy by highlighting community members who chose to be inoculated. So I, of course, have added my story, and you can too. It only takes about 2 minutes. And I think that together, as we all do this, we can continue to encourage people who are still on the fence to finally go and get their vaccine. And by the way, all of our applications are supported in dozens of languages as a way to ensure that everyone has the same opportunity to access the latest resources available to them. And geography supports one other kind of communication I wanted to cover. You can do very targeted messaging on important issues like vaccine confidence. We're working with the US CDC to combine information on attitudes, research data, lifestyle information, and the channels through which people get their information to hopefully increase vaccine uptake for COVID, certainly, and for all vaccines. So honestly, this is just the tip of the iceberg. So much of our pandemic response requires location awareness. And our global pandemic story, you know this, it has so many tragedies. But I wanted to highlight that it also has triumphs too. Health, and especially health IT, has never been more important. And I certainly want to thank you for your attention. I look forward to our discussion. And at this point, I'm going to turn it over to Jim.
Excellent, excellent. I always enjoy seeing that. And the share is enabled for me. This has a chance of going well. Okay, can you hear me okay?
You're up and running.
Great. I'm going to hit present and let me know if you see a full screen slide.
Yep, you're good.
Wonderful, thank you. And then lastly, yeah, let's just get going here. So I'm Jim Harris. I'm a geographer. I really enjoy hearing from Frank and Esty because they are two of my heroes And this screen represents one reason why, that the columns you're seeing here are how we started out mapping COVID in my little neck of the woods. So someone like Este has a very broad view across all of public health. And someone like Frank is working with every country in the world, and in many cases, many provinces as well, to obtain data. And what you need to know about my perspective is that I'm just a wrench turner in the cartography part of Living Atlas. And this is kind of my view, or my initial view, of the excellent data that Frank provided. It shows the total number of cases, the active cases, and the number of deaths by country. And this is kind of how it started. And as Frank showed, the dashboard, here's the dashboard screenshot from March 18th of 2020. And you'll note on this, the map is just showing a count of total cases for China as a whole, and then different provinces in China, and then Europe and the States. And so the map does a great job mixing states with countries, depending on what point we're trying to drive home. And of course, the rest of the dashboard begins to illuminate this topic just from a simple count of total cases, total deaths, total recovered. And then a year later, the map is very similar, much more detailed, more granularity, as Frank said earlier. We're showing counties in the United States. We're showing many states and provinces throughout South America, mostly countries in Africa, and more detail throughout the rest of the world. And we're now at 126 million global cases. And then this was a screenshot from yesterday, 12/14, showing 271 million cases. The thing I just want to point out is that every map has its limitations, right? That a map of counts from the start to halfway through to where we are today, particularly these last two maps, if you just go back and forth, a lot of the overall impression of a map of counts doesn't change too much. And that's why the value add with the dashboard is over here in further exploring the different dimensions of the data. So how it starts with is, well, what data can we gather? But every team looking to analyze this looks to take that basic data and add context to it. So from the left, what country or other geographic unit are we talking about? Do we have a population estimate for that country from a reliable source? How many days have we been tracking this country as having cases? And in this case, my colleague Charlie Fry, who is the author of this particular table, began to work with Johns Hopkins data to sort of understand, how do we characterize it? Because after you get to the count, you kind of want to know, well, what do these numbers mean? And that's what so many people in the public and in policy, government, and business, they want to know, what does this mean for me? How do I need to change? Or how do I need to propose change? And so everybody takes that raw data and starts to build information around it. And as a result, what I noticed from my lonely perch, just trying to work with Charlie to get the most out of this data, is as the data improves, we start to think beyond the basic facts of counts of cases and percents of cases. We now start thinking about how things are changing over time. Are counts increasing or decreasing? New cases per week. Increasing, or new cases per week decreasing? Are we having a positive effect on the thing we're trying to get control of? Are things accelerating or decelerating is another way to phrase it. And what is the right map to show in order to stimulate thinking? At what time and to whom? And what's the right map to create? These are all the kind of questions we see over and over when we're making maps. So at first we go from maps of counts to maps of rates. And if you just kind of glance across here, some of these were the first maps Charlie made about what are the current trends with COVID by country, and then applying the same technique in the United States by state and by county. But also showing maps like this one, the number of days since the last new case, or the mortality rate over here on the left. highlighting recent outbreaks in a very clear manner to help officials understand your area or areas near your area are having an outbreak. Sometimes a map of change is just as simple as showing, well, what is the change? This COVID Pulse application was authored by the Living Atlas team, inspired by John Nelson, a cartographer at Esri, and using a particular style of a visual graph, in this case indicating, look here at Iowa, had a big spike and then it fell off and then now is rising again. So they're kind of on a second wave. But look at Louisiana. It appears to indicate this is actually a third or perhaps a fourth wave, just like Mississippi, third or fourth wave. And so when you pause on this map, the principle we always try to create is let's reward the user with information. So if you pause over North Carolina, it gives you some key facts about the population and some of the key rates, 1 death per 552 people, and etc. And then another way to help motivate people is to rank things. Tell me where North Carolina ranks out of 51 states, and including District of Columbia. Where does North Carolina rank where a high number like 34 or 40 is actually good? You want to be ranked 51st, right? If you're number 1 in cases or fatality rates, you probably deserve some additional attention. Oh, and what we particularly like about this particular application, it's entirely loaded into a browser's memory, all the data, all the user interface. So it's very scalable and works very nicely to deliver this information, again, updated daily from the Johns Hopkins data. I said people are interested in change, and I started thinking about the topic of COVID and maps of counts, and I started to think about this topic. Which way are things going in my area? And as Esty showed earlier, we kind of worked with Charlie to work up this map showing in purple areas are having increasing number of cases. And as you can see from the pop-up, Charlie actually wrote Python code that puts all of this information together for me every day, or I'm sorry, once a week. This is a weekly update. And tells me for this county, Tobacco County in New Mexico, which is right here in the middle of the screen, you can see it as a big purple arrow with a big drop shadow. And it says, Charlie has assessed the numbers and he sees that this is strongly worse for 2 weeks in a row. So cartographically, I want to make sure this thing gets a big arrow with a big drop shadow and it stands out. And in this case, it stands out with maybe 1 or 2 other counties in the same state, whereas evidently Iowa and Illinois are having a tough time in nearly every county. So Charlie's code actually would write these pieces of information into the database so that all I have to do is plug that in once a week. It takes me about a grand total of 3 minutes to update this map each week and just kind of check around to see, is the cartography still working? Do I need to make any other adjustments? And the whole inspiration of doing this, I kind of thought about it from the perspective, we've all taken an airline flight and we all have a clear expectation of how an airline flight works, right? You start out on the ground, you will climb to a cruising altitude, and at some point the captain will come on and tell you, we're going to descend now. So take your seats, and if you do so, we can land. And if you get up out of your seats on landing approach, they'll probably do a go around, won't they? And I started thinking about that difference with COVID is we don't know what to expect. We hope we're going to land at some point and get to 0 cases. But right now, all we can do is kind of report, are we climbing or are we descending? What are we actually doing? And that's what I think a lot of people benefit from. In addition, they benefit from having a quick summarization. We built this dashboard off that same web map to simply summarize for the media from the left, which counties have the most new cases per week, which ones have the highest active case rates, which ones have had the most consecutive weeks improving. So Missoula County, Montana, as of this week, had 9 weeks of improvement. And then it gives numbers over the past 2 weeks just for context, which is fantastic. And the converse, tell me which counties are doing the worst, the longest. So Fountain County, Indiana, is strongly worse for 7 weeks. It's in the midst of this purple blob. Lastly, a word about animations. I like them, but I think a lot of people struggle to find meaning in animations. And in this case, we worked with a very smart developer named, sorry for the ad, a very smart developer named Christian Akenis built this animation off the daily summary of COVID data to kind of animate the data and help people understand this moves in waves. And this tool allows someone to explore several different use cases, density of cases, or total count, or how many different counties are increasing or decreasing over time. And the thing we kind of learned about animation is it's like rebuilding the data set. You know, how do you feed an animation daily? You've got to make sure you've got a good source to begin with. And then the thing you kind of see in the interface, it's not just about playing it through day by day, but also finding significant events like July 4th or Memorial Day. Sturgis is another one. If you go to this link that I'll provide, you can see different events and how its effect in the following 6 weeks spread throughout the country. So I'll conclude by saying, you know, all of these maps try to have a purpose. I work on a team called Policy Mapping, where we look to reveal where there's an opportunity to intervene on any given topic. So with COVID, of course, we want to get the basic facts of cases and rates out. We want to get essential facts. I remember all the mapping quickly pivoting to how many hospital beds are available, how many ICU beds are available, because that is one of the more important factors involved with policymaking. Who is faring well? An advocacy map to show who needs a little more help, who stands to benefit, and who stands to lose by policy mapping options. One map I made for the National Governors Association of the 50 states showed what policies were in effect in each state and allowed direct comparison state to state. Never saw the light of day, never made public, but it did influence that particular group just to understand who is doing what. And lastly, who is in compliance, who's not in compliance with any given policies, who has benefited or not benefited after the event is over or while it's concluding. Like, how can we analyze our work to see, did we actually make an impact with our decisions? And here's the visual proof. In map form, it can be very entertaining and educational to kind of just reveal the different patterns going on. And I think that's why I was very attracted and continue to be attracted to how do we influence the maps that are going out there. So I want to thank you. I'll conclude here and yield the floor to John. Stop sharing.
Sit here. Share just and just move a little bit. Yeah, that's right. I'll sit here.
Okay, good evening, ladies and gentlemen. My name is Gianni Campanile. I'm from Esri, Italia. Here, headquarters in Rome, the Italian distributor for Esri. I'm glad I heard from my colleagues that we faced the same problems and challenges during these terrible years. And I'm talking about in their amazing presentation, they stressed that availability of data and also questions about what to present and how to show data was really challenging and was the key point about building tools that could help people in facing all the pandemic situation. This was happening both at worldwide, but also at local level. And what I will show, it's something that focused on the Campania region, because we had a project working there, and we were working with the Campania region while the pandemic started. And so we had the opportunity to get to gain access to daily basis data, and so to try to build tools that could help people people involved in facing the COVID. Now, the first thing we tried to understand it, what was needed, what was asked for. And so we thought that we needed simple tools, very quick answers, and to have an overview of the situation at scalable levels, and also to show trends of different parameters, which is obviously something that Johns Hopkins dashboard and the pulse map that came quite afterwards, and all tools you saw in those amazing presentation were focused on. We also thought about in which areas we could really give some nice tools to help. And the first thing we thought of was how to keep situation of words under control. So we thought about showing real-time availability of beds, especially in words, in general in words, but also in special words, taking care of COVID diseases. So we thought about that, collecting data with the survey app, which is an Esri app that can be easily configured and used, and then to use a dashboard to show bed availability. Then we thought that regional decision makers should have daily and overall statistics about the situation. And on this, we will see that we focused more on tests than on actual cases, positive cases and deaths. But the concept of a dashboard inspired by Johns Hopkins was always there. Also, that the regional level civil protection wanted to have trends, and so when the pulse map with the representation of trends appeared, we thought it was really a good way to represent trends. And then I will show you that instead of having trends, it was time to show vaccines there. So we readapted the pulse map. So about words, bed availability in words. As I said, it was built up as a flow between word users that could use a simple survey to input data on bed availability. We used Integromat, which is a sort of a internet glue that has the availability of making calculations whenever a survey is submitted. And this is because when we published the service on ArcGIS Online, and we realized the dashboard, this was the easiest way to have some totals that could not be easily calculated. So this is the overall flow that obviously involved the word users, word controllers, and general regional level controllers. And this is the example. As you see, it's a very, very simple, very basic survey, but this was realized in really a couple of days. And it was the beginning of 2020. So it was 2021, sorry. And so it was the situation, it was still under control. And so it was really useful and easily accepted. This is the Integromat flow that shows that from survey, it makes some calculation. It shows that not only it makes some calculation, but also it triggers some Telegram messages to people that want to keep under control when data arrives. And this is the dashboard. Again, it's a very, very basic dashboard, but this gave us the opportunity to realize that in a few days, and immediately shows the situation where red, of course, means something not very nice. Now, don't bother the numbers because this was taken from a development environment. All the slides I have is from development environment, so it's the situation. It's not that bad, and numbers are much more. In real world are much better, but so you see, it's a very, very simple one that gives a situation of bed availability and splitting between free beds confirmed under investigation or occupied. So this is still in use, and this was the second application we developed, and was a complex dashboard inspired by the Johns Hopkins one. But as I said before, it was focused on the tests and positive cases more than on just the positive cases. So the idea was to keep track on how many confirmed cases were in percentage on the tests made and on the population. So this is in fact, it is a double dashboard, one that shows the situation at the general level, and another one that will show that shows the trends at province and municipality level. So as you see, when I zoom, obviously I can select one of the province of municipality that is dark red. Dark red means that number of cases at last 2 weeks, this is focused on the last 2 weeks, is high. This does not mean that the percentage of the cases among the tests made and with the population, it's high. So to do that, I have another visualization that is this, that shows the size of the circle shows the total population, and the color shows the ratio between the number of cases and the population. So when the color is red, it means that the number of cases is high in percentage of the population. And you can see this, for example, in this country, in this municipality, the number of positive cases, the percentage of positive cases is quite high. Of course, when I select one item, all the dashboard gets updated just like the Johns Hopkins one. So you see 15%, it was quite high. Again, this is not actual real-time data. This is taken from the development environment, and it's also and it is regarding some months ago. To have a trend, we developed another dashboard which is on the same frame of the first one, but it's completely different. And this, with a heat map, can show concentrations during, again, the last 2 weeks. And on the right side, on the right side in the low part of the dashboard, you can see that there is the trend of the new cases that so you can see what's going on. You can see that here, for example, there was a high, some peaks, and then it went down. So what we thought is that we could create one dashboard and have both an overall situation, a local situation down to municipality level, and also some trends. I must say that this was not as quick as the first one we saw, and it was very challenging to find the best solution and the best representation of data. And at the end, it was not really widespread because it was quite, I don't say, it was quite complicated. But the problem is that everyone was absolutely out of time, was nobody had enough time to understand and to listen to what they could do, and this was one of the reasons why this dashboard, I think, was not really used at its highest potential. So at that point, the pulse map was available, and so we thought that to show trends both for tests and more not for deaths. I mean, the original pulse map is positive cases and deaths. Instead, we changed that, and we had tests and vaccines, and we realized that the pulse map, obviously always based on the Campania region, and the functionality, it's almost the same. It's obviously the same. So when I click on a province, I can see the trends, and I can see the trends both for positive cases and vaccines. Obviously, when I zoom in, I go down to, this is for province level. When I zoom in, I go to municipality level. And what I think I like is something that I will show in moments, is that the pulse map has another visualization, that it's not only on a map, but it's also on a grid, which shows all municipality of a province in a decreasing or increasing order, and so you can see what is going really on the overall level, which is this one. So you see that, for example, this is in decreasing level on total vaccines, and you can see that in some cases there are some spikes, just like here in Pollica, and sometimes instead the trend is quite at the same level. So this gives an overall view at municipality level in a certain order, and I can choose obviously 100 days, just like in the original pulse map, and we find it extremely useful. I have some conclusions, but I think that these conclusions are almost the same that my colleagues found. But I think that the good thing is that we developed, sometimes in very short time, applications that really helped the sanitary personnel and decision makers. But there was also some bad. Honestly, we did not spend enough time to choose the best representation. Nobody had enough time. Everybody was really pressed and tired, and not only there was this sensation of losing time, looking things that were not the real job to do. It seems not to be the real job to do. And so I think that when there is enough time, we should work on solve these problems. Now, unlike Sergio Leone's masterpiece, I don't have the ugly, but just I have some lessons learned. And we think that the most important thing is to keep things as simple as possible. And remember that in emergency situations, nobody has enough time. So we have to spend time to collect data, to find, to build what we need when we are not in emergency situations. So I have some additional consideration, which, as I said, are quite similar to the ones of my colleagues. Data is vital. It must be available, certified, fixed format. I mean, we had to face with 3, 4, 5 different formats coming from different sources. Sometimes they were completely different, and this obviously led to to big problem to deal with that, and then to uncertainty about what was the real data. And one thing, I mean, Esther made a wonderful presentation, but I must say what she mentioned and what she showed is what it should be, geoanalysis. I mean, we tried to spend some time in building tools for contact tracing, to use not only dashboard based on attribute aggregation, because when I showed the dashboard, I mean, the aggregation is made at province level and at municipality level, which is something which is yes, it is related to geography, but nobody is making, for example, aggregation or cluster analysis at the road level to find hotspot. So location-based analysis is still absolutely underestimated, and it's quite important. And I think that we need a new geographic approach and the collaboration to really exploit geography and to face these emergency situation. Okay, thank you very much.
Thank you, everyone. Wonderful presentations, and I really liked the way that they sort of complemented each other. So Frank started out talking about the challenges for data collection and the opportunities for data sharing. And then Jim talked about adding meaning to that data, not just having the data, but creating a story from the data, creating a message from the data. And then Johnny just explained to us how that was a thing that they were able to do at a more local level. And given the limited resources, limited time, limited energy, they were still able to create resources that people were able to use to take the data that started way back at Johns Hopkins, maybe moved through a filter that Jim and some of the folks at Esri worked on with the various apps and such, and then still create something that was useful for their local area. And then Esti gave us a really nice broad overview of the various ways that GIS can be used in health, and more connections between health and place than ever before. So we're all here now. You can see us on video. Tim is with us as well. I thought what I would do is start with a directed question towards each of our panelists, something that caught my attention while they were speaking. And then I would start asking some more broad questions. Is that okay with everybody? And Tim, is that all right with you too? Cool.
Sure.
All right, I'm going to start with Essie, and I'm going to start with kind of a big question, a broad question. And after Estie's response, if you other panelists would like to add something, just pipe on up. I think one of the things that you really focused on, Esty, is how people started thinking differently, thinking spatially about health issues in response to the pandemic. So do you think that people will continue to think the way that they've sort of had to think during the pandemic? Do you think they'll continue to think and act and analyze spatially, or do you think that they might sort of go back to how things were prior to the pandemic?
I think both. There's a lot of people out there, and I'm not quite sure which way the majority will go. But we're already seeing some of both. We see people who have used their GIS for pandemic response, and even though we're still in it, of course, they're seeing the broader application. They're starting to create more apps for different health workflows and seeing the value. They're thinking deeper about some of the applications they stood up for COVID and enhancing their dashboards or adding more materials, including equity in some of their analyses. So I definitely see the positive. That gives me a lot of hope that that there is going to be a movement forward in how GIS is applied and used in health. But we're also seeing some negative things, at least from my perspective, but I think we probably can all agree. and in some way they're unavoidable. The pandemic is going on a long time. It doesn't surprise me at all, but there's a lot of burnout. Public health, for example, has always been under-resourced. And so then you have this emergency on top of that, all hands on deck. And then at least in the US and probably in other places around the world, public health or health in general has become politicized. And so people who always were just trying to do their good work and follow their mission to help improve health outcomes in their jurisdiction are now suffering from social media and letters and phone calls that are negative that they didn't really have to deal with before. So we're seeing an understaffed workforce leaving public health, and some of those people are taking with them some of the GIS knowledge that they had. Others who are remaining in their jobs are feeling burned out. Maybe, when you're burned out, you're certainly not thinking of innovation and what can I do next with technology to make lives better. You're just trying to keep your head above water. So definitely two sides of the coin. There is a broad range, but we definitely see movement. There is hope. I'm gonna put my bet on that horse that things going forward are going to be expanded, but I recognize it's not going to be across the board. There will always be organizations that need a little extra help, a little more motivation, or maybe more time to get there.
Thanks. Any comments from the other panelists? I kind of want to jump up.
You've got one, go ahead.
Yes, I think that thanks to really the Johns Hopkins dashboard, I mean, at least my daily experience now is that when I go to customers and I start talking about GIS, I have a good starting point. I mean, I don't have to anymore explain what a GIS or a dashboard or what they could do with that. At least I start from there. That's something that everybody knows, unfortunately, I must say. So that gives me the opportunity to start going really into what I said, the geography approach, which is something that I mean, is a sort of a geospatial analysis that could be much deeper if data could be available. And this is always the same big problem, at least here in Italy. But this, from what I heard from you, I think it's a worldwide problem everywhere. I mean.
So that kind of leads me to something to ask Frank, which is what do you think the world would be like if that Johns Hopkins dashboard had not been developed?
Well, that's a hypothetical question. It's really hard to answer. But what I can say for sure is the data collection effort will still be there, maybe made by WHO, maybe made by US CDC, or maybe New York Times. They will still reporting the US cases. However, maybe their reporting scale or granularity won't be that helpful. So from the starting of this project, and my purpose as a researcher, I think this data collection effort is by the researchers for the researchers. So we will know the pain of doing research without a very data in details, like in the county level or even the census tract level. So without the dashboard, for sure, there will be data collection, but that won't be that helpful, especially for the local user. And also, there might not be real-time updating like what we are doing. And for that sense, I really appreciate what the Esri can do for us because they made the tool there. And so I can build up the dashboard just overnight within 8 or 9 hours. So that one is something I really appreciate of.
Yeah, you mentioned that data sharing is so important, always was from the very beginning of the creation of the dashboard, that you knew that you wanted to share that data. And, maybe that wouldn't have been the same if it had been a different entity, not a university, not a research institute that was collecting and putting together and managing the data from the outset. So let me go to Jim then. You consumed the data and you, as you mentioned, and as I caught from your presentation that was very important is that you tried to give meaning to the data. And one of the things that Frank mentioned is that they were not trying to correct any data. They weren't trying to change the data. They were reporting what was coming in. Did you give thought to, and did you try to do anything with the quality of the data or any reporting of any errors in it or omissions or problems with the data?
Yeah, that's a great question. All data is flawed. Some data sets report their flaws or share their uncertainty. And I really like how Frank presented, and Johns Hopkins throughout has just been, this is what we have. And when there's anomalies, we explain it and we discuss it. So my connection to the data was through Charlie Fry, who he and I would talk, and we began to notice the data, the daily variability in the numbers you could see on many charts, Monday, Tuesday, Wednesday, Thursday, Friday, and then Saturday, nothing, Sunday, nothing. And it's like, really? Everybody just stops getting COVID on Saturday and Sunday? That's unusual. So you begin to start to realize, no, there's a system in place. I have a good friend who's a general practitioner, a doctor, runs a practice at Kaiser Permanente. And so we would compare notes about how data gets reported. And it's that point where Charlie began to think, if we stopped focusing on the daily and took a cue from Johns Hopkins and began to look at weekly, it just creates a little buffer for that day-to-day reporting variability, and maybe monthly, et cetera. So that's where that COVID pulse and other maps, we began to think about, if you change the period of time, it has an effect of kind of smoothing out what's going on. It lets you kind of ask different questions. And so having Johns Hopkins dashboard is beautiful to consume, but knowing that the layer that powers it is available with day-to-day, I believe now we also have a week-to-week layer, and that's where the map of purple and gold arrows came from. So by just shifting the time period, it allowed us to ask different questions. And I think that's important. The people who work hard on the data, I've noticed this on project after project, people who work hard on the data are sometimes the best people with ideas about how that data might be represented. But oftentimes they may not be up to date on the specific capabilities of ArcGIS or QGIS or any other platform. So they may not be the best to execute on it. And so people like me try to jump in to act as an intermediary between the data and the people whose full-time job is feeding that beast, and the representation of that data and the people asking questions, because that's for me anyway, it's been full-time employment for 25 years. And I see that repeating in public health indefinitely. People need answers, and they need people who can translate data into information.
And Johnny, that's what you were doing as well with your variations on the dashboard, variations on COVID Pulse. You are giving meaning to the local area Jim was talking about weekly data, but you were even looking at how many beds were available on a daily basis. So you were bringing the granularity back down again to answer, address issues that were on a local level. So can you speak a little bit about how, as Jim was saying, you're taking the data, maybe not, there are people who maybe aren't the right ones to be doing the working with the data, but you were doing that. So can you speak a little bit to that?
Yes, I mean, as I said, I mean, we interface different people, and I like what Jim said. I mean, I want to go back on that. But now, to answer your question, we started talking to people which were very much involved in the situation, and we had an immediate answer, immediate interest in having a tool that could help them. This was very exciting for us. I mean, they gave us a real good support, and we I don't know how, but we found the right road, the right way to represent what they were asking for. And this is exactly what Jim was saying. I mean, one thing that came out in a very clear way during this year is that not only we need tools, not only we need data, but we need people that could transform data into information. This is something that now it's starting to become clear, not only to maybe to us, which are working daily with this with these topics, but also to our customers when we go there. Now I feel that there is some more I must say attention to this. They understand that to have a good and understandable representation, it's not only a matter of good tools, of a lot of data. You need something in the middle. You need a translator. And it's not an easy task, because this person must understand about the needs, about perhaps, I don't know, in these cases, statistics, sometimes, of course, GIS, sometimes raw data, sometimes how to interact with different systems to understand the capability and the limits of each system. So again, when we started the second phase, the second tools, it was we were sort of I must say very happy about the first acceptance of what we realized. And I said that the second tool was we made it I must say too much. We wanted too much to have in one tool, and that's an error. And what happened is that only 2 or 3 people had enough time or attention, or I don't know what it is, to use what we realize. And that's a pity, because the dashboard is really full of information. It was very, very useful, but it was too much. It was too complicated. I really appreciate what Frank showed, because not only the classic John Hopkins, he showed some other representation, and I really find it extremely simple, but at the same time meaningful. And this is a very difficult task to achieve. And this is something I must honestly say that with the dashboard, we realized we did not really made the complete goal. The pulse map was much better, and it was much better also because it was sort of more, I would say, optimistic, because I said it was not talking about deaths but about vaccines. So I don't know, maybe that helped a little bit. And so we show trends, and it was nice. It was easy to understand. So our experience with people and data let us understood that it's difficult, and you must be very, very patient and clean. I mean, understand that complexity is not always it's not always the best way to represent things. And
Yeah.
okay.
Yeah. As a cartographer, that totally resonates with me. It's almost always a good idea to take things off a map instead of putting them on a map when you're trying to increase communication. Let me ask a broad question for all of you. Do you think, as a result of the pandemic and the resources that people became used to, like the Johns Hopkins dashboard and the real-time availability of information and more localized information, knowing what's going on around you and not just at say the level of the country, or even in the United States or states, do you think that people are going to expect that in the future, and not just for health issues, but other types of issues as well? And do you think that we are, as a global GIS community and other communities, able to provide that, if that is what people expect?
I can start on that one. I think absolutely it will become an expectation. Something like this, you can't unsee, you can't unknow that it's possible. And I think that's how we often open the door to innovation. You know, I go back to one of my favorite stories of Roger Bannister running the 4-minute mile. Nobody thought it was possible. As soon as he did it, 30 people did it the next year. So it's now that everybody knows it can be done, it's been done widely, it's been seen globally. We cannot unknow or unsee it. We will continue to demand it, I believe.
Mhm.
Yeah, I think that's a really good point. And also, I want to add, not only in a different field, they know the power of the science of aware, they know the power of geoscience. They also know the power of the effects of the geoscience on different generations. For example, I've been getting some interesting stories from the high school students. They are checking our map daily, and from this one, they not only know the public health, they not only know the pandemic, they also know the GIS, they know the spatial thinking. So I think in that term, the dashboard really helped on spreading the concept of the GIS and the geography.
This is Jim. I
Johnny?
know I'm grateful to see more maps and statistics related to this topic shown in all types of media. And I think it gives us that initial placement where now we can raise our game and maybe change the narrative from, the local news is probably the worst in this country, where they'll just tell you 452 new cases today. What do I do with that? Compared to what? Is that a good number? Is that a bad number? I would love to know. So I think we all can collectively up our game and raise the expectations of the media context that we do have. And that's something we're working towards by just trying to provide better examples and pushing those first. And I know that's a long-term effort.
Let me talk a little bit about data collection. As Esty mentioned, this effort of collecting data and sharing it, especially in real time, was just not something that was really the thing for health data previously. It was reported later, it was cleaned, et cetera, et cetera. So there were delays between when things were happening and when the data could be collected. That obviously changed with pandemic, and there are still, as Frank mentioned, there are still gaps and issues with data quality. But do you think that the requirements for collecting and sharing data have changed, and will they remain that way from now on? Will there be different data collection and sharing efforts, and will it be more than just health data? And do you see it already happening?
Well, I'm a project manager for central and local public administration. So I work with well, the problem of collecting data at that level in public administration, or maybe even in local administration, is quite a big problem. There are many sources, and many times you not even know who is the authoritative one. So now talking about this experience, so this was on public health, and this is much more complex than usual data, because there are many problems, privacy, sensitive data. So as far as I can see, especially on public health, I see a much more attention to define who can collect data, who can disseminate it, and who is the authoritative sources. So at least I see some efforts to define to define better workflows than the ones we had before. I must also say that at general level for public administration, it's not always the same. There are a lot of initiatives of collecting data that was never collected before. I'm working on some interesting projects, but I think it's a long way to go still.
I have to agree with you there, Gianni. I think that data collection has and data availability has expanded incredibly since I first started in GIS. There's so much data available, and yet, of course, we always complain that we don't have enough or we don't have the right data. And I think that problem is going to continue. I'm not sure that I think the pandemic is going to make that better or make that happen much faster. I think people have been working on it and will continue to work on it. What I hope does happen as a result of the pandemic is maybe in some way it accelerates the questions that we're asking and the resolutions to those questions, particularly for health data. Gianni brought it up, privacy, data security issues. People want the data, they would like to be able to collect it. Some of our tools like Survey123 can support collecting that data. But there's always the concern about, are we doing it properly? Are we maintaining the protections around the data and personal health information that need to be managed? And then, of course, the IT questions. Are we sharing properly? Do we have interoperability of our data and standardization with other systems? These questions were being addressed before. Maybe they'll be addressed a little bit faster, but I would say I'm not 100% optimistic about that, just because it's always been kind of an issue.
Tim, can I turn the floor over to you to offer some observations, maybe ask some additional questions?
Sure, thanks. Maybe what I'll do, I'm going to do a couple things. One, I'm going to try to stitch the presentations together in kind of a flow. And then I do have one general question that I'd like to ask each of the panelists, and give you time to think about that for a second. And then I'll ask a couple other questions or make a couple other points, and then we'll come back to that question. So starting out with Esti's presentation, which was phenomenal, extremely comprehensive, and it covered the breadth of the whole issue, and with a great deal of specificity. So it wasn't just a general presentation. There were a lot of key points that were there that I think we need to dissect. We need to go in and tear that apart and start thinking about, you know, what do those things mean? What impacts do they have? What agenda are kind of evolving from that? Then we go to Frank, and Frank really talked about the data and the technology and the processes. So it was get the data, load it into newly developed technologies and applications, and then develop a process by which you do that on some level of frequency. And I really think the construct of having rules about that process were incredibly important. You took what you got, you processed what you got, and you delivered what you got. You didn't try to alter the data, which actually gave you efficacy. So that was, I think, important, even though people like myself are so frustrated with the data. So that I think was really important. Then we went to Jim, and Jim, basically it was a derivative process. Took the data and started to evaluate it, and not evaluate the data, but evaluate the impact of the data through mapping, showing different kinds of maps and different implied stories with the designs and with the content. And then we went to Gianni, and Gianni, in effect, gave us a case study with Italy, or a portion of Italy. But he changed the subject. So before, we were always talking about the individual, about cases, about deaths, and he started talking about hospital beds. So that's a very different construct. That's like, you know, we're not talking about instances of something. We're now talking about, well, how do we react to those instances? And what's our preparedness and what's our availability or what's our plan for addressing those instances? And I haven't heard enough about that because we're always in a reactionary mode when it comes to emergency response. We're never planning for it. We're always reacting to it. And that always puts us at a disadvantage. So, and you know, this pandemic's not over, and it has changed over time. So, getting a little bit of background noise here. And I don't understand what they're saying, so that even makes it more frustrating, but okay. Right, so my question then is, if each of you had you know, based on all the things that you were faced with and that you know and that you've seen, what would you like to see differently? What would you change if you had the opportunity to change it? Not with what you did necessarily, but how you were impacted by the realities of what you were working within. And while you're thinking about that, I'm just going to go off on a tangent a little bit and talk for a second about the data side itself. It really concerns me that when you, first of all, we're in an international conference, so I want to think about this in an international context, right? So when you have some countries that have fairly low level of geography, and I don't think we're at the level where we need to be, that's a different question. And then you have other countries that have one number for the whole country. And you're bringing these into the same system and you're reporting out those numbers. That's a problem. And so, and it's not just a problem with the numbers, it's a problem for the people that are reflected in those numbers and the countries that are serving up those numbers. And that talks about, to some extent, capacity, capability. It could be politics. In other words, they don't want to have disaggregated data within a country. That could be the case. But I think in this particular situation, I think it was probably in more cases than not, just the hard reality that they didn't have a mechanism to have lower levels of geography reflected. So that's something that pandemic or economics or, you know, healthcare as a whole or social circumstance, that's something that needs to be worked on in a very general way with specific results. The other thing I would say about data is that, and I tell this story a lot, so if you've heard it, I'm sorry, but I live in one county. My zip code is in a different county. So whatever numbers are reported, if I were reporting COVID for me, those numbers were reported in a different county. And that has an impact on so many different things. That could impact those hospital beds. It could impact the number of vaccines that go into that county. It could impact all kinds of things. And I'll just say it out loud. I think that we need to be talking about household level data for this kind of an event. Because if you stop and think about where we were at the beginning, we did not know how this virus spread. We had no idea. And so the instances of where the disease was or where the virus was most critical at that time. Yet we did not have data for that. And I'm thinking about in my own case in the United States, but it's true globally. So if we had had that, maybe something different could have been done from a healthcare perspective, a policy perspective, on and on. And I think, as we kind of alluded to in this discussion, it does beg policy questions. And to me, a core question is personal privacy more important than death? That's a question that somebody needs to be talking about. You know, that's an important question. And I think that we ought to be using these examples that we've experienced as a way to begin to enumerate those issues so that that dialogue and that discussion can take place. All right, I'll stop and get off that soapbox and then come back to my panelists. So Esri, if you had, you know, an opportunity to make a change or see something different than what you know or what you've experienced or what you've observed, what would that be?
Well, this is probably a very broad answer, but I would certainly like to see GIS as a stronger part of the fabric of public health response, perhaps even the core technology, and that geographic perspective becomes central and not an afterthought or a sideline map or a dashboard, that it's a part of the way we think about responding to emergencies, disasters, pandemics, whatever kind of crisis. I think that to get there, we need foundational data. We need, you mentioned we're always responding, we're not as prepared as we could be. I think that's very true. And I think, we in the GIS field have multiple times enumerated the steps to get there. You start with building your foundational data, and you have core capabilities within your staff so that you can quickly do things like stand up a dashboard, collect a little more data, connect a data set to another, and create an information product. So, but the information product requires the spatial thinking. That, again, requires practice. You have to be able to take that geographic perspective and turn it into a value statement for how you solve a problem. So I guess, my summary line is I'd like to see lots of things change, but I think people would be able to respond much faster and much better if GIS was thought of as a critical, major component of public health preparedness and response.
Thank you. Frank. Oh, sorry, I'm going to come back to you, John. Frank, go ahead.
Yeah, thanks, Esty, and thanks, team. So if I get the chance to start over of the project, maybe I will think about the many other things like the server. So I remember in the beginning, our server is shared with another company. So when a lot of users jump into our dashboard, there is no way we can host those visits. So we have to upgrade up a server to a standalone server, and with the help from Esri. So maybe for the next pandemic, if we know the volume of the users, we need to prepare from the baseline of the infrastructure of the server. The second one, maybe I will think about the definition. I know I'm not criticizing any of the organizations that like WHO or US CDC, but they did a good job on collecting data, even for historical, like the measles, dengue, and other infectious disease data. However, for this time, for this pandemic, they don't provide guidance on what data to collect and how to define a certain public health terms, such as what is the case and what is the death, even though that's one is really clear to most people. But if you go to the really details of the technical thing, it's really blurred. For example, like the death, how you count when someone is die of COVID or die with COVID. And I know in Texas, even the government said only someone die with a certificate which show he died of COVID, then he's a COVID death. Even though that someone just died earlier with some other disease, even with the COVID, that won't count. So the definition of the disease is really unclear, even though we have the Esri and other geospatial technology ready, but we don't have the framework of the how to use those data. We need to set up the very early, and I think CDC or WHO can help on that. And as for the team mentioned, you wish the household information could be provided, but that one will also raise the question about the privacy concern. I remember there is one county in Massachusetts, that is Island County. They only have reported maybe 2 cases. However, it's really easy for the local people to find out who that two people are. So in the end, we combine those 2 cases with with cases from another county close by, and then we'll share it to the public. So it's a trade-off. Maybe in the future, we can have 2 systems. One system is reported to the government officials. They have the detailed information, like even at the household level. And the other data is good enough for the public to get awareness of the seriousness of the pandemic. Maybe that one can at the county level or census tract level. And for that scale is also good for researchers. So that will be my insight. Thanks.
Yeah, thank you. And I think you're starting to outline a path forward. Aileen, I just want to do a time check. We have to be out of here in 6 minutes, so they're going to shut the building down. So I'll go on to Jim, please.
Sure, very briefly, I experienced that we need more room. So it's human nature that when under stress and we're trying to build a data set and deploy it and support it and make a map out of it and a dashboard and another dashboard, we tend to get conservative in order to ensure that we deliver, right? But simultaneously, we need another channel that allows creativity. We need to create room for people to interpret. We need to loosen up the GIS people. They are so used to making a 5-class Jenks natural breaks map. They're on autopilot. They're not thinking. They're not asking the right questions. They need to be loosened up. GIS analysts doing amazing work need to understand that sometimes the visuals that come out of GIS analysis are so technical in nature, that narrows the audience. And that's okay when you have a narrow audience, but if you want to broaden the audience, you've got to dumb it down. And that is at odds with what a lot of scientists are taught to do. It's just a reality. They need help. That's why we try to help. But they need to loosen up that as well. And we need to have that channel of creative expression of good science, good data. Otherwise, I have found I have to fight and claw my way into projects on behalf of creatives I'm working with in order to just get an opportunity. And when we have the opportunity, it allows us to create a higher expectation so that the local news stops running maps of counts and starts talking about the things Johnny represented, the things that we are doing about the counts. Thank you.
Thanks. You know, yesterday at our opening ceremony, we had the president of the International Science Council basically say the research has to be applied, practical, and useful, to be meaningful. So that was good advice. Gianni, please.
Yes, very quickly. As I already said, I mean, the dashboard was too technical, but you talked about the bed and the wards. Yes, what I would do what I would do in another, I'm saying another life, is to share much more the results, because the bed availability was inspected by managers, but it was not, for example, to people or to physicians that wanted to address people to certain hospitals where bed availability was higher. So it's a matter of sharing as much as possible GIS information. And for the future, I would like also to that it would be, as it seems to me, weird not to know the bed availability in a hospital. I mean, I would like to have it as a normal people. I mean, as a
Citizen,
yeah,
yeah.
citizen. Yeah, I would say.
My final comment, Aileen, is that I've got 100 questions I didn't ask. So this is the beginning of this conversation, and I strongly recommend that we continue this dialogue and do it as quickly as we can over time. Thank you.
Okay, well, we'll wrap up the session now with a big thank you to all of our panelists, to Tim, to Paola again thank you very much for organizing this whole thing, and also to all the participants who came and listened and learned, and I hope that we do carry this conversation on. We'll give some thought to how we can do that and what we can do next. And so everybody, enjoy the rest of your conference. Panelists, Tim, again, thank you, all of you, and same for the audience. Thank you.
Thanks for your contributions.
Thank you.
Thank you, Tim.
Bye,
Thank you,
everyone.
Bye.
Thanks very much, Jan.
Good job, Frank. Good job, Tim.